Afternoon, everyone. If my voice is audible and the screen is clear, so we can start our session for today. So please give me a feedback just in the chat room. Say yes, say no, as you wish. Is it clear?
Yes, Dr. Hassan, it's clear. Welcome.
Okay, thank you. Thank you, everyone. Today is an extraordinary day. Actually, when I choose the date prior to maybe the last month, I didn't get that today will be the ceremony opening of World Cup, okay, which is an amazing event, happened every 4 years. I think most of you will not be interested in in something like this, but it's really a very important thing for the whole nations and whole people worldwide, because I'm always feeling that in the ceremony opening of the World Cup, all people, different colors, different languages, different religions, everything, they are communicating properly, and they are trying to enjoy their lives purely. And this is a very important message. Now the ceremony is still live, but we have to go for another live about the updates in postpartum pelvic floor problems. And this is our title for today. And I would like to thank you all in advance that you joined this session, because I like to make this session like a very simple and a very interesting topic, rather than being too much sophisticated, because pelvic floor is sophisticated, by the way, and the practice in our regular practice, this is a subspecialty which is rarely most of candidates are dealing with. So somehow it's like a taboo, like you have to start from scratch to cover everything in pelvic floor problems. So I wish I will make it easy as much as I can. This is actually a Tog article, summarization of a Tog article released 4 months ago, or maybe 6 months ago. It was published to discuss about the pelvic floor problems in a woman postnatal, and how can we judge the different kinds of problems related to that. So simply, when we are talking about part 2 MRCOG, you have to know some important sources to study from. So of course, all of you know that Green Top guidelines are considered the top priority source to study from, and it's the highest body of evidence as well. So the second option is the NICE guidelines, which are just concerned about certain topics like urogyny, like infertility, and some medical disorders with pregnancy. And then the third source, which I consider very important, is Tog articles. The Tog articles are, in the last maybe 6 years, a very good and important source of questions, especially in single best answers. What I can imagine that we are going to a new era in part 2 and part 3 examinations. From the last patch of part 3, which finished maybe previous week, and from the last 2 patches of MRCOG part 2 exam, I can realize that the college is changing the bank of questions, and the college is trying to make it more difficult just to control somehow the success rates. Don't be scared, and just try to think outside the box. We are not here together just to I'm giving you some information and you are trying to remember them. This is not the game. The game is I'm here to help you to reformat your way of thinking in different questions. This is what I exactly said to all candidates in part 3. Part 3, I can find people like they are memorizing 130 stations. Definitely, they did that. And they get inside the exam and get outside after that said, Dr. Hassan, it was a very strange exam. No recalls. Actually, the game regarding recalls is almost finished. You have to try to change your mind towards Royal College exams because they are changing the policy. So if you could not be able to change your policy as well, you will be in a big trouble. So another point of view regarding the pelvic floor, okay, problems. Pregnancy and delivery both considered one of the major risk factors regarding pelvic floor problems. They are maybe associated with pelvic muscle trauma, pelvic muscle redundancy, weakness, and this will markedly affect the ability to control urine and stools as well. So it will affect the quality of life. Now, regarding the pregnancy and puerperium time, there are some physiological changes happen within a woman. Like, for example, because of the labor process itself, infections may be increased, the risk of infections. Incontinence may happen because of weakness of the muscles, as well as the OAB, overactive bladder incontinence, may happen under the effect of progesterone, leads to stretched bladder. Sometimes bladder trauma during labor, which is considered or known as distension bladder injury, may happen as well. And it leads maybe to another kind of bladder problems, which is well known as atonic bladder. The atonic bladder, the patient cannot feel any sense to go to the bathroom. There is no sensations regarding the distension of the bladder. That's why those patients are suffering from overflow incontinence, which means when the bladder, urine inside the bladder exceeds the maximum capacity of the bladder, the intravesical pressure will exceed the maximum urethral sphincter closure pressure. So the urine will start to flow. Overflow incontinence. And then sometimes patients may suffer from another kind of retention because of natural edema. Okay, natural edema. Which year the topic of Tog is under discussion? Which year? This one, 2022. This year. Okay, that's great. Now, just to summarize, we have different kinds of incontinence. One of the most famous is stress urinary incontinence, which is defined as involuntary loss of urine on effort or with any increase in abdominal pressure. Sometimes the patient with sneezing, laughing, coughing, lifting heavy objects, or doing exercise aggressively, they may experience skip urine without control. Now, please notice that the stress urinary incontinence is anatomical dysfunction. It's anatomical problem. When the neck of bladder is descended, below its normal position. So somehow it lost the valvular action. The valvular action. Why this descent happened? Because of weakness of pelvic floor muscles and ligaments and support. This anatomical problem is considered the commonest type of urinary incontinence during pregnancy and outside pregnancy. It may reach up to 75% of women in pregnancy. They have at least one experience with loss of urine involuntarily. Okay. Of course, by increasing the gestational age, this problem may be more obvious because the pressure of the baby's head or presenting part on the bladder itself, decreasing as well the maximum bladder capacity. Okay. The screen is not visible. Is this your problem alone, or all people cannot see the screen as well? And of course, the recording will be available. It's visible. So please, you can relog again. Just get outside and please relog again. The problem will be solved. Okay, thank you. Now, it's without any doubt that vaginal route delivery is associated with higher risks of stress urinary incontinence and pelvic floor trauma than elective cesarean section. However, some authors consider that emergency second stage cesarean section is almost the same risk of vaginal route delivery. Okay, it's around 8% higher risk of persistent SUI in postpartum period. How to manage? This is the question. Is it conservative, or I have to do some interventions? Now, it's believed that lifestyle modifications like decrease the amount of fluid intake, avoid caffeinated drinks, decrease the stressful life, weight loss if possible. All of these lifestyle modifications are considered primary advice to any woman with SUI. But the actual first line treatment for those patients should be conservative by pelvic floor muscle training. And this is the best option to start with those patients. Mostly, the pelvic floor muscle training takes about 3 months consecutively with a professional physiotherapist in the form of 8 contractions 3 times daily for 3 months. This aims to strengthen the pelvic floor muscles, so decreasing the risk of SUI and controlling the symptoms. The second option, what do you think is better if this first line failed? Is it the surgical treatment, or I can try medical treatment? What do you think? Which will be more effective in SUI? Any suggestions? I would go for surgical or medical treatment. What do you think? Which is better? Let's see how people thinking. Shaista said surgical. Any other suggestions? I will explain it easily. Now, if you have, now some people said surgical, some people said medical. Now, if you have anatomical problem, so surgical management, exactly, Shaista, thank you. So surgical management is the best. Okay, if I have a prolapse, vaginal prolapse, surgery, cystocele correction is the best. Okay, if I have a functional problem, so medical treatment is the best. You got my point. I will give you a very simple example. It's far away. Now, a patient with heavy menstrual bleeding. We have two groups of causes: organic anatomical problems like fibroids, like polyps, like adenomyosis, or endometrial cancer. Okay. On the other hand, we have dysfunctional uterine bleeding, which are functional problems. There is no obvious lesion like iatrogenic or with medical disorders, bleeding with medical disorders, dysfunctional uterine bleeding. So the management definitely in organic HMP will be by surgical removal of polyp, surgical removal of myoma, hysterectomy with adenomyosis, hysterectomy with endometrial cancer. But how can you manage a patient with dysfunctional uterine bleeding? I will manage it by medical treatment, like even Mirena, tranexamic acid, or cyclical hormonal treatment. You get my point. So SUI is anatomical problem. So surgical management supposed to be the best option. However, surgical treatment is not usually considered until the woman's family is completed. Okay. It means that if the woman is still young age and she had a problem like SUI and she's still planning for further pregnancies, so surgery is not the ideal option, because simply with the next delivery, next pregnancy, she will suffer from many other problems. Now, if you would like to choose a surgical treatment for a woman with SUI, you will go for the best option, the gold standard option, which is called Birch colposuspension. Here, this is a very simple view to the technique, which is not involved in your curriculum, by the way, but just for fun. This is the bladder in the center of the picture. I will go through the retropubic space. This is the retropubic space, which is called Ritz space. The bladder will be shifted to the contralateral side, while I will work, for example, in the ipsilateral side. I will take the vagina by the blue color. Now look at the blue arrow. This is the vagina. I will take the vagina and stretch it to be suspended to the ilioinguinal pectineal ligament by 2 or 3 stitches. The same will be done on the other side. Now, colpo means vagina. Suspensions, I did the procedure easily. It seems to be easy, of course, but in the real life, it requires some experience, because this area is rich in venous blood. So you have to be very smart and cautious to avoid any bleeding points. Okay, so this is the recommended surgical best gold standard method to treat SUI, instead of previously using the transvaginal tape or transobturator tape. Tapes and mesh surgeries are suspended in UK because of the long-term consequences. Like, now, if we suppose, my friends, that TVT will not be used anymore in your exam, TOT is the same, and then we have only other 2 options for the patient. Okay, we have something called paraurethral bulking agent injection. the name that they know, the market name is called Bulkamid. Okay, just you will insert a bulking agent, inject a bulking agent pre-urethral to support the bladder neck and elevate it upwards to the normal position. This will be really helpful to control the symptoms. However, the re-injection in those patients may be required after 6 months. That's why it's not considered the permanent treatment. For your knowledge, Bulkamid can be used in cases of, number 1, recurrence after failed surgery. Number 2, if the patient is frail, so the major surgery will be difficult and risky for her, so she can move towards a simple procedure like urethral bulking agent injection. Now, sometimes the patient may refuse all kinds of interventions. At this point, medical treatment called duloxetine will be the only option to treat SUI. Under which family duloxetine is present? Duloxetine is SNRI, serotonin noradrenaline reuptake inhibitor group. So it controls significantly the increasing the urethral pressures, closure pressure. So it controls the involuntary escaping of urine from the patient. That's great. The second kind of incontinence problem is called overactive bladder. The old terminology was the urge incontinence. When I was in the college, not the Royal College, I mean my college, Cairo University, pre-graduate, we learned the name of urge incontinence. This name is nowadays replaced completely by the terminology of overactive bladder. It means that the bladder muscle, the detrusor muscle, being insane and hypersensitive to any distension. That's why patients with OAB are suffering from urgency, frequency, and sometimes associated with nocturia. Because with minimal distension to the bladder, the woman feels urge to evacuate. Okay. Sometimes the OAB in pregnancy and puerperium may be misdiagnosed with urinary tract infection, which is more, of course, common than OAB in either pregnancy or postpartum. One of the major keywords to differentiate between both conditions is burning sensation during micturition. Burning sensation is a leading word to diagnose infection. While there is no burning, no pain during micturition, if the woman is only suffering from urgency frequency like OAB condition. Up to 40% of women in pregnancy, I need all of you to check the mics, please. Close my side. Okay, thank you. Hello, Dr. Samreen, how are you? Around 40% of women in pregnancy, even in the first trimester, they are complaining of micturition, frequency, and urgency. Unlikely to the stress urinary incontinence, there is no association, most probably, between parity and OAB. The parity is one of the major risk factors for SUI, not in OAB. This means that OEB mostly is not an anatomical dysfunction. It's a functional problem. Keep it in your mind. There is no obvious lesion. I cannot detect anything, but the woman is suffering from some sort of incontinence. Another very important point, let me ask you a question. If the woman is complaining of urgency frequency, but she still can control herself, is this situation considered OEB or not? What do you think? Exactly. Now, it seems like all of you, it seems like all of you or most of you had the, the old urge incontinence listen in pre-graduate time, I think. So it's like me exactly. Because yes, when the name was urge incontinence, we have two types of urge incontinence. It could be wet, it means frequency urgency with incontinence. The patient cannot hold herself. And dry urge incontinence means just frequency and urgency, but the patient can hold herself until reaching the bathroom. What is that means? How can you translate it in a good knowledge point? It means that incontinence is not necessary to diagnose OEB. OEB is diagnosed from symptoms, urgency, frequency. While in SUI, incontinence is mandatory to diagnose it, because all of us, if the intra-abdominal pressure increased for any reason, there is no incontinence, no leakage, so we are normal. Okay? If there is no leakage in SUI, it is not SUI. This is a normal person. So leakage is critical to diagnose SUI, while it is not necessary to diagnose OEB. Patient may be an OEB, but without incontinence. How to manage? As usual, primary, conservative, exactly like SUI. Lifestyle modification, reducing or stopping caffeine intake, bladder retraining, and this is the first line option to manage OAB. The bladder retraining should be done with trained nurse for 6 weeks continuously, okay? And this bladder retraining is equivalent to pelvic floor muscle exercise as a primary or first line management to the SUI. So here we will start with bladder retraining. However, sometimes it's not effective enough. And I'm always saying that OEB patient is a very poor patient because the improvement in her condition is not, obvious. So she is always suffering and complaining. So she will move through multiple lines of treatment, which almost not effective, and sometimes it may end like with a major surgery. Now, please remember, I said that OEB is a functional problem. So the second line management is mandatory by medical treatment, not surgical treatment. It's not like SUI. SUI is an anatomical problem. So surgical treatment is the next step. While in OEB, it's functional problem. So if bladder retraining not improving the situation, I will go for medical treatment. The medical treatments are abundant, and this is not the site to to discuss the detailed medications because it's already discussed in the Urogynecology NICE guideline. But I just would like to mention some important medications. So we are always starting by a treatment from anticholinergic medications family called oxybutynin. Oxybutynin immediate release is the best option to start with. Other types may be sulfenacine or darifenacine. They are used maybe together, combined treatment, if the oxybutynin treatment failed to control the symptoms. However, the whole family of anticholinergic medications are associated with very strong side effects, most commonly dry mouth. Imagine that 88% of patients on oxybutynin, they discontinue treatment because they cannot adapt with the severe dry mouth they are suffering from. Even maybe they are improving with the oxybutynin regarding their symptoms, but they cannot be able to keep taking the treatment because of the side effects. Anticholinergic medications are safe to be given in pregnancy or breastfeeding. So it's a very nice option to be used either in pregnancy or postnatal if the woman is suffering from OEB. Sometimes, and this is extremely tricky and extremely important for EMQs, sometimes because of breastfeeding and increasing the levels of prolactin in serum, which is normally antagonize estrogen effect. So estrogen relatively postnatal will be decreased. This may lead to a vaginal mucosal atrophy and periurethral atrophy as well. That's why some women may suffer from OEB symptoms postnatal, as well as dyspareunia postnatal. Why? Because of the vaginal dryness and mucosal atrophy. So it seems very logic that in a woman with breastfeeding period, she can be offered local vaginal estrogen cream to enhance and improve the vaginal mucosa, as well as the periurethral mucosa, and improve the OEB symptoms. It's as same as the management of menopausal women with OEB. You have to think about vaginal estrogen cream. At this point, if the medical treatment failed to control the symptoms, now we will go for the third line, which is almost interventional and surgical. The first option in surgical treatment for OEB is botulinum toxin injection in the bladder muscle. Botox are a paralyzing agent to the muscles. So when I inject Botox in any muscle, the muscle will be paralyzed. And this is what we are aiming to do if the bladder muscle is not controlled by medical treatment. However, it could be used in pregnancy, but it's not recommended. So you will not offer this option in your exam for a pregnant woman or even postnatal. Why? Because the paralysis of the bladder muscle may be associated with urinary retention. And urinary retention is one of the risks with pregnancy already. So you are increasing or doubling the risk of urinary retention. Please notice that Botox is the first interventional option. The second interventional accepted option for OEB treatment is sacral nerve modulation or posterior tibial nerve stimulation. So neuromodulation is the second option. This should never be used during pregnancy. Some important tips to summarize. Now, the prevalence of all lower urinary tract symptoms reduced already after 6 weeks of delivery. So don't try to judge before 6 weeks postpartum. That's why follow-up without any intervention is the recommended management plan. The incidence of OAB symptoms is higher at 6 weeks postpartum in those who delivered by vaginal route rather than a cesarean section. Now it seems that cesarean section carries a lot of advantages. Am I right? The long-term incidence of SUI symptoms is higher as well in vaginal deliveries compared to cesarean section. It seems very logical. Now, some women may suffer from a pelvic organ prolapse just after delivery or in the last trimester in pregnancy. This around 10% of women may show some sort of prolapse problem. The prolapse should not be evaluated until at least 6 weeks postpartum. The relaxin muscle released in the last, few days in pregnancy and during labor and after delivery leads to a muscle weakness and redundancy. Ligaments will be more weak. So a picture of prolapse may be prominent, but all of these will be subsided after a while when the nature of the muscles and ligaments return to normal, which was before pregnancy and labor. Different kinds of prolapse could be detected, of course. The cystocele when the anterior vaginal wall is very weak, so the bladder invaginated in the anterior vaginal wall. Posterior vaginal wall weak, so leads to rectocele. Uterine prolapse when the uterus itself is below its normal position, and if there is removed uterus, so maybe the vault is descended as well. What are the important risk factors that leads to increase the risk of POP in later life? In instrumental delivery, as well as prolonged second stage of labor, macrosomic baby delivery, and if the woman had a 3rd or 4th degree prenatal tears. So these are very important risk factors. You can expect that the woman will suffer from POP one day in her life. How can I manage POP? If the POP is diagnosed for the first time in pregnancy, so conservative management should be offered. The aim of the treatment not to correct the descent, it's just to improve the symptoms. Treatments as same as incontinence problems will be summarized in lifestyle modification, exercise, lose weight, and sometimes vaginal pessaries may be offered. This is the conservative management in pregnancy and 6 weeks postpartum. If the woman is not completed yet her family, she will follow the same conservative management plan. But if she completed her family and she is not desiring any fertility anymore, she can go for a surgical correction. If the woman would like to go for a surgical correction, most probably the suspension surgeries should be offered. if the uterus is descended, so hysteropexy will be done. If there is a cystocele or rectocele, so classical repair should be offered. Okay. Another problem related to pregnancy and postnatal period, it's urinary tract infections. In this Tog article, they give a very, very precise information regarding the nature, symptoms, management of urinary tract infections in pregnancy and postnatal. Maybe UTI is the commonest medical condition to be happen in pregnancy. Approximately 8% of women, which may increase to 25%, 1 in 4, with asymptomatic bacteria women may suffer from UTI symptoms during pregnancy. And if not treated well, they may complicate into pyelonephritis in 2%. The most important risk factor for UTI in pregnancy is asymptomatic bacteria. The UTI during pregnancy may be associated with some consequences like preterm labor, premature rupture of membranes leads to chorioamnitis, stillbirth, and small for gestational age. That's why I need to treat infections in pregnancy and of course postnatal to avoid complications. Classically, the woman will have a triad of symptoms: dysuria or burning micturition with frequency and urgency. So this triad is very classic, as we discussed before. The first line investigation is a urine dipstick analysis. The most common organism leading to UTI in pregnancy is the gram-negative bacilli E. coli, around 80% of patients. Now, the treatments are almost the same after the culture and sensitivity to choose the most suitable antibiotic given in pregnancy. But we have another problem I think we need to discuss properly: the recurrent urinary tract infection. The recurrent urinary tract infection is defined as 3 or more attacks of UTI annually, or more than two or more attacks in 6 months. UTI is a very tricky topic, the recurrent UTI. I will give you a very simple example. If you have a patient with recurrent UTI, she had maybe 4 or 5 times attack of UTI annually, what do you think the cause may be? What is the cause? What is the cause? Any suggestions?
Low immunity, being a female, short urethra, urinary anomalies.
That's great. That's great. So let me take you through my question. If the patient in a childbearing period, what is the most common cause of recurrent UTI? Impossible to be a congenital problem. Impossible to be, the recurrent UTI is age dependent in the exam. Exactly. Mariam, Suraya, exactly. It's age dependent. So if you have a patient with recurrent UTI, she is a child. I have to think about parasitic infestation or foreign body. I'm right? Excellent. So if this patient is teenager, I have to think about, is she amenorrheic or not? Because sometimes Mullerian duct anomalies, Mullerian duct is giving the origin of the upper genital tract and the urinary tract as well. So yes, Maliha, thank you. You got my point. So if you have a patient 17 years old with, she's amenorrheic and she's only complaining of dyspareunia and recurrent attacks of urinary tract infections. So you have to think about Mullerian duct anomaly. She will be most probably Mayer-Rokitansky or androgen insensitivity syndrome. Now the recurrent UTI is taking you to definitely another point of diagnosis and discussion. Okay, if the woman suffering from recurrent UTI in childbearing period, I have to think about unprotected sexual activities. If the woman is suffering from recurrent UTI post-menopausal, I have to think about either low immunity or cancers, okay? A cancer underlying cause. So this topic, particularly in exam, they are loving recurrent UTI in the exam, and they get previously we had questions in the previous patches of the exam. All are discussing recurrent UTI from different points of views according to the patient's age. So this is really important topic. Okay. Now, postpartum, postmenopausal are the most common patients to suffer from recurrent UTI or UTI overall. The other main risk factors for recurrent UTI are younger than 15 years of age, maternal family history, frequency of sexual unprotected intercourse, high parity, low socioeconomic class, and urinary tract abnormalities. How can I treat? The Tog article suggesting trimethoprim, okay, which should be avoided in the first trimester, or nitrofurantoin, and should be avoided at term. So either the trimethoprim or nitrofurantoin. Trimethoprim, you cannot give it in the first trimester, but it's safe furtherly. And nitrofurantoin should not be given in the last trimester. I mean, around 36 or 35 weeks, because it leads to some bleeding tendencies during delivery. Penicillin family still can be used in pregnancy and very safe, as well as cefalexin, cephalosporin treatment. Don't forget to give the patient local estrogen cream to enhance the vaginal mucosa and periurethral mucosa. Now, this is the additional things you need to think and remember in your exam, because they are somehow new techniques in the treatment of recurrent UTI patients. Lactoferrin, ascorbic acid, vitamin C, and D-mannose can be used to improve the symptoms and prevent the recurrence, and all considered safe during pregnancy and postpartum. For those patients with recurrent urinary tract infection, you have to test their urine every 2 weeks in pregnancy until 36 weeks of gestation, and then weekly until delivery, to be sure there is no hidden asymptomatic bacteria. So this recommendation is important in single pest answer questions. If I told you that the college is obsessed by urinary retention conditions, you may not believe me, but believe me, they are obsessed with urinary retention conditions. in the part 3 examination, second day, sorry, the 14th of November, on Monday, I was in the exam and my station was postpartum urinary retention problem. Exactly a forceps patient. The patient underwent forceps delivery and there was a bladder distension injury. And the patient, after 2 weeks, she still cannot feel anything and she is using a catheter. Okay, and how can you manage? So urinary retention is not an uncommon problem, by the way. It's maybe around 1 in 4 patients after traumatic delivery or prolonged second stage, sometimes large size baby, sometimes within emergency cesarean section and traumatic manipulation to the bladder. Urine retention may happen in the form of atonic bladder. Sometimes you have to insert a catheter to the patient and remove it. If the patient within 6 hours cannot pass urine spontaneously, she should be diagnosed as urinary retention. Thus, I can evaluate the degree of retention by doing a very simple procedure to assess the post-void residual volume. How much urine are still trapped in the bladder after evacuation. Okay. Please notice that the urine retention may be physiological and may be pathological. We are hearing discuss the physiological problems because, for example, if the patient had cervical cancer and the cancer invading the urethra, so the pathway is obstructed. Now the patient suffering from urinary retention, but the cause is very well known. Okay. If the patient had a forceps delivery and then there is no urine at all, urine retention, because there is a big hematoma compressing the urethra. Okay. This is an obstructive urine retention. But what we are concerned about today is the dysfunctional urinary retention. Okay. What are the risk factors? Epidural. Epidural. It's extremely important with urinary problems. In part 3, if the candidate missed to ask about if the patient undergo epidural during labor or not, he should be marked as borderline directly. This is critically important risk factor in your exam. Prolonged first and second stage of labor, instrumental traumatic delivery, second stage cesarean section, sometimes in prima gravida woman, sometimes with episiotomy and pain down below. Okay, so all of these are important risk factors that may lead to urinary retention. How can I manage urinary retention? It's extremely easy. This is a copy-paste algorithm from the Tog article. Now forget about this. The whole answer is related to this. If the patient is unable to void in and out catheter to assess. Sorry, I just muted everyone from my side. So I need to assess the residual volume. How can I do that? I can either put a catheter and collect the remnants inside, or to do an ultrasound to assess the post-void urine residual volume. If it's from 150 to 250, give her another attempt to void after 6 hours of removal of the catheter. This is maybe a very mild situation and the patient will be able to void. But if the amount is up to 700 milli, insert a catheter and retry to remove it and give the patient a trial of spontaneous void in 24 hours. If the amount of urine inside is more than 700 milli, please put a catheter.
معلش مسكة بسيطة ضغطة بسيطة تحطيها.
Please put a catheter and let the patient to go home with a catheter for 2 weeks and then re-evaluate your condition. This is a change.
تحملش عرق والعرق يسجع عليها. هي دار.
I tried to close her mic 3 times before. Henrik, unable to void in 4 hours or 6 hours of catheter removal. No, you will insert the catheter, another trial to evacuate everything, and then remove the catheter, give her a chance to spontaneous void in 6 hours. If she cannot again void within 6 hours, put the catheter for 24 hours, okay? So if the amount is less than 250 millis, proceed attempt at second void at 6 hours post catheter removal. If she's still unable to void, turn her to the management of insert a catheter and retry to remove it again in 24 hours. Now, what are the changes in the new recommendations from previous one? Previously, regardless the amount of urine inside, the patient will be offered 24 hours to 48 hours catheter inside, and then we will try to remove the catheter and give her a chance to pee. If she still cannot do this, I will insert the catheter and leave it for 1 week. This was the previous recommendation. Now the new recommendation, and it could be coming in your next exam, you should follow these recommendations according to the post-void urine amount. Okay, I hope it's easy and all of you will remember this. Before finishing our session, I will be very happy to to all our friends who would like to attend more and more with mid-exam expert mentors, different mentors, me, Dr. Zaip, Dr. Bradnia, as we are conducting this course for the last 7 years, actually. I have a coupon, which will be like a gift for a discount to join part 2 MRCOG July 2023 patch. We are start to build up the principles of this course from now, just to be able to finish this course in a proper time and give people a proper time to study and revise. This is very important. For the last 7 years, I was pleased and honored to help my dear colleagues and friends worldwide, India, Pakistan, Gulf, Egypt, UK, Vietnam, Nepal, Hong Kong, Singapore, even in Barbados, to pass MRCOG exam, part 2 and part 3. And I'm really feeling proud and very happy to practice teaching and to, you know, discuss difficult topics with all colleagues worldwide, because it's still keeping your mind working and raising up your capacity, raising up your effectiveness in your job and in your work. When you are trying always to read, to update yourself, this will dramatically reflect on your practice. So that's how I can keep myself in the track, and I'm really happy of that. So the mid-exam experts are working hardly for the last 7 years to help MRCOG candidates worldwide, and I'm a part of this, so I'm really proud of that. So I will be very grateful to all of you for attending this session. And I think the gift, yeah, if you would like to, you know, take this coupon gift, you can contact the MRCOG Part 2 team and mid-exam expert, as well as there will be a link, a contacted link to all of you to join through. Now, this is a time of questions. Anybody would like to ask any question? Yes, the recording for this webinar will be sent shortly, Khalid. Any questions? Any, you know, difficult points you may not understanding well? The bladder training, Rosina, bladder training for 6 weeks. Please remember that pelvic floor muscle training for SUI is for 3 months, while the bladder training for OAB is for 6 weeks. So if question asked first line SUI lifestyle management, weight loss or reduced caffeine? Maliha, what do you think? I will tell you a secret. Reduced caffeine is the most recommended thing in lifestyle modification. Again, I need you, I need your brain to be reformat again. Let me ask you a question, Maliha. Be with me. Reduced caffeine. If I reduce the caffeine and I have anatomical dysfunction, is the anatomical dysfunction will be managed? No. So it is not suitable for SUI as the best lifestyle modification. But if the patient lost weight, I think it will be markedly affecting her anatomical problem. On the other hand, the irritated bladder muscle may be becoming less irritant if the caffeinated drinks stopped. Am I right? So what is the most important lifestyle modification for SUI? It's a weight loss. What is the most important lifestyle modification for OEB? It's stopping caffeinated drinks. Okay, seems logic. Yes. Now let's take another question. Yeah. Yes, what is meaning of dry and wet OEB? Dr. Khalid, dry, there is no dry and wet OEB. They are all called like OEB. Previously, urge incontinence was classified into dry and wet. Dry if the irritated bladder is not associated with leakage. Wet if it's associated with leakage. So this was a very old terminology. So don't put it in your mind. I'm just remembering this because I need you to understand that leakage. leakage is not necessary point for a diagnosis of OEB. Okay. Caffeine, good idea. Rule of sublingual vaccine in it's still not evidence-based. Okay, so you will not use it in the exam. Management of volt prolapse. This is a completely another guideline, but rapidly, I will summarize this guideline in 3 words. Listen to me. 3 words. You have 3 management plans for volt prolapse. Number 1, conservative. When the patient is very old, refusing surgery, or unfit for surgery. Conservative. If the volt prolapse is mild or grade 1, I can offer pelvic floor muscle exercise. If it's significant prolapse, I will use pessary. Okay, so this is the first part, conservative management. The second part is prophylactic management. I need to prevent volt prolapse. So at the time of vaginal hysterectomy, I will do McCool-Coldoplasty just to suture the volt to the uterosacral ligaments and cardinal transverse cervical ligaments to support the volt. If the hysterectomy is through the tummy or the abdominal hysterectomy, I will do Moscovich procedure, the same technique, but from upside. This is the second topic, prophylactic. The third one is curative management. The woman is already had now volt prolapse and she is asking for definitive treatment. So if the woman is sexually active and or has a short vagina, I will go for abdominal sacrocolpopexy. Abdominal sacrocolpopexy. Otherwise, the default surgery to correct the volt prolapse is sacrospinous fixation, SSF. SSF should be offered to all women except SS, short vagina and sexually active woman. Finally, in cases of recurrence, or if the patient is not sexually active and she is old age, but she's asking for definitive treatment rather than the pessaries or something like this, we can go for a surgery called colpochliosis. Colpochliosis is just to remove the volt and close the anterior vaginal wall to posterior vaginal wall. You will close the tract. It's simple, easy, and less time consuming than other surgeries as well. So this is the management of volt prolapse. Red Rose, can you cover management of POP with SUI? Offered and occult. Yeah, that's great. Now, simply, SUI, of course, all of these questions should be discussed in urogynecology session. I'm today just giving you the postpartum Tog article, but I will answer you, by the way. SUI with prolapse, if you have a cystocele, anterior compartment prolapse, and then which treatment you should start first, to treat the prolapse or to treat the SUI, which procedure you will go for. Now, if the woman had SUI with the prolapse, both together, I mean offered prolapse, so you should go to correct the prolapse first. the prolapse first, okay? Because the prolapse is maybe leads to kinking of the bladder neck. So when it's corrected, the symptoms may be subsided. After that, if the patient is still suffering from the symptoms, she should go for vertical suspension. With occult SUI, with prolapse, it means that if the prolapse is corrected by hands, I correct the prolapse by my hands and ask the patient to cough. Now the problem mainly is not related to the prolapse. So if the patient suffering from SUI, correct the SUI first. Okay, red rose. Lifestyle modification or pelvic floor muscle training is the first line management for stress incontinence. And same is for OEB, lifestyle or bladder training. Lifestyle and then bladder training. Okay, Rabia, let's say that. The primary management, lifestyle modifications in both problems. Then the first line management, pelvic floor muscle training in stress, bladder retraining in OEB. Is that clear? Excellent. I hope it's clear. Yeah. This is, just a very important and simple explanations to most of, query questions regarding the pelvic floor problems. I hope all of you gain the maximum benefit of this session. I'm always being happy to see people and to talk to them, to answer questions, and even to discuss questions. Sometimes I may miss something. Sometimes I'm not confident enough to give a final answer. So I will go back to revise, as well as I will ask maybe you to answer the question. So this is how the knowledge is increasing, expanding, and how your brain is being formatted again towards the exam questions. This is what we need all to work with. Red Rose again asking, concomitant treatment will worsen the condition if the patient has POP and SUI. No. If the woman, look at this, if the woman had a prolapse, anterior vaginal wall prolapse, and SUI visible with the prolapse. So if I correct the prolapse, the symptoms may be corrected. Yes or no? Yes. So I will start by correcting the prolapse. But if the woman had no SUI when the prolapse is there, but with reduction of prolapse, SUI start to be obvious. It means that the prolapse blocking or obscuring the SUI symptoms. When I reduce the prolapse, the woman now considered normal person. She has SUI. So I will correct the SUI regardless the prolapse. So I will start by SUI first. It will not affecting the outcome. Thanks everyone. And forget everything about prolapse, about SUI, and go rapidly to see the first match in World Cup 2022 in Qatar. Okay? Studying knowledge guidelines will never be finished. Okay? But the happy moments will be finished soon. So try to enjoy your time and enjoy the match, everyone. Thank you so much for being with me for more than 1 hour in this session. And I wish all the best to all of you and see you soon, either in part 2 or in part 3. Bye bye.